I am what you would call a full-time interdisciplinary sleep specialist. Spent about 3 years of my life subspecializing in this area after initial training in neuropsychiatry. But I practice sleep medicine exclusively, and I deal with a full spectrum of sleep disorders. And there are about 85 different conditions that by now we can effectively diagnose and treat. And don't worry, I'm not going to go through all the 85 over lunchtime. We also do quite a bit of clinical trials. Practically every drug that made it to the market in North America or Europe, we have been involved in its testing one way or another. And then in the last few years, which I'm not going to talk so much about it today, but we took the science and the clinical aspect to its applied level in terms of shift work operations and the whole issue of fatigue management in transportation, 24/7 operations, etc. So it's really a full service kind of a setting, okay? What I'm going to be talking about is very much a group effort, and you probably know these individuals much better than you know me. Adriana, when Bristol Myers Squibb realized that there is nothing in this area out there, in spite of how common sleep problems are in general, but also in the various HIV clinics, then they identified an infectious disease expert, which was Michael Silverman, and Adriana, who I think that is in the audience here, okay? And this was very much a group effort in putting together a general overview aimed primarily at clinicians, but I think that is applicable to any one of us. Now, it can be stretched anywhere from the 25 minutes that I'm going to be trying to squeeze it into to about an hour and a half, depending on the nature of the audience. Bottom line, there is no particular conflict of interest. It was put together with a grant support by Bristol Myers Squibb, but from the standpoint of any work that I did in the past, I worked with every one of those major companies, including grant money from various government entities. Anyway, what I'm going to try to do is give a very quick overview of how to incorporate sleep assessment as a regular, time-effective component in assessment and follow-up of patients with HIV, how to screen for some of the more common sleep disorders, how to utilize both behavioral measures as a first-line treatment and medications when it's appropriate, and also know when to refer a patient and seek the additional expertise, whether of mental health professionals or in particular sleep specialists, okay? We'll also start with very quick presentation of 2 cases that came from Michael's practice, and then cover some of the epidemiology, the impact, various aspects of management, and revisit those 2 cases. Now, in the original package, okay, there is quite a bit of a discussion about the cases, and there are placemats and various tools that the clinicians can have and use in their practice. If anyone is interested in getting those tools subsequently, then send me an email, and I'll be glad to provide that. And you can reach me through the OHTN connection, okay? So the first case is a young lad, 18 years old, diagnosed with HIV about 2 months ago, not going to go through the viral status, etc., and he was prescribed efavirenz, okay, comes back complaining 2 weeks later after initiating therapy of severe nightmares, okay, causing him to relive sexual abuse that he suffered during childhood. He's afraid to go to sleep, and it's clearly associated chronologically with the onset of ART medication. What would you do? Anyone? People went to sleep already, okay? All right, we'll get back into that. He's not interested because one of the first knee-jerk reactions that sometimes can be exercised there It's the medication that is causing that effect, okay? So let's try to switch it, okay? And one of the key messages here that that's not needed, okay? Now, typically what you find with this kind of a presentation, and it's interesting, a lot of those nightmares have a sexual content and a sexual connotation. What I heard from quite a few patients, that it's not necessarily disturbing. Some individuals actually find those sexual dreams quite pleasant and are not interested in making it go away, okay? But in case that it's not, okay, then the question is, how do we manage it appropriately without necessarily having to change the medication? And it's not receptive to the change anyway. Options were not really available at that point. They became available since then. Okay, so we'll get towards the end at what was the effective intervention in this case. This is more a typical patient that I see practically 20 of those easily in a day. Okay, 47 years old male, recent immigrant. Okay, the only difference there is that I don't necessarily see 20 of those with HIV status. Was prescribed again a single tablet. Okay. Comes back, is overweight, type 2 diabetes, hyperlipidemia, elevated blood pressure, which is almost a package that goes together in a lot of those patients with a kind of presentation of a metabolic syndrome. But one of the key messages to anyone that is thinking what that could be, that you don't have to have that in order to have a significant degree of that condition. Anyone wants to stick their neck out and give an idea of what he could be suffering from? Bingo. Okay. All right. So he's being managed for his diabetes. Okay. And he is reporting increasing fatigue since starting on the medication. Again, a chronological connection there. But it could be just the straw that broke the camel's back, or now suddenly he has something to hang it on, okay? Again, this is a typical blood work that we frequently are doing, in particular looking at testosterone, TSH, etc., to rule out various medical conditions that could be contributing to it. And we'll get back to how do we assess that in terms of referral to a sleep laboratory assessment by a sleep specialist, etc. Anyway, the bottom line, that those sleep problems are very common, okay, in this audience in general. If you are in any way a representation of the general public, they are very common in your loved ones, whether those are your kids, your partners, etc. And they are also extremely common, and for a variety of reasons, there are some additional factors that come in with some of the patients that you are dealing with. And it has to do with the fact that effect on the central nervous system, which controls also the sleep and wake cycle, is frequently one of the first manifestations of an HIV infection. Sleep problems are being believed to be experienced anywhere from 30 to 100% of HIV-positive adults, depending on the definition that is being used. And it's really important to differentiate between the occasional disturbance, which some of those studies and the surveys are using, which we all have. And what I mean by a disturbance is in relation to a particular stress, medical condition, surgery, etc., having some problems with your sleep that might be lasting for a few days to a few weeks. The problem is when it becomes a vicious cycle, taking on a life of its own. And when it becomes a chronic problem that has a significant impact on the individual's functioning, whether physiologically, psychologically, occupationally, or educationally, that's when we call it a sleep disorder. But when we talk about disorders, we are not talking about the occasional disturbance. And then it becomes much more difficult to identify a cause and effect relationship, which is not so much straightforward anymore. Okay? Fragmented sleep is typically not one of the more common presentations. A lot of the patients that you're dealing with will be complaining much more of daytime fatigue and sleepiness, and there is a combination of reasons for that. Difficulties with cognitive functioning, memory, concentration, decision-making ability, reaction time, etc. Okay, and the bottom line is that in the majority of the cases, those conditions go significantly underdiagnosed and undertreated. Okay? Those are some studies, including a Canadian study at the bottom. 73% had a sleep disturbance according to the Pittsburgh Sleep Quality Index. A cross-sectional study of adults with HIV, 45% slept less than 6 hours per night. How many people here got more than 6 hours of sleep last night? Some, good for you. How many got less than 6 hours of sleep? Less than 5? Okay. How many of you got less sleep than what you know that you need? And we have to ask ourselves, why are we doing that? Okay? Why are we shortchanging ourselves? And we'll talk about how much you actually need. Okay? Anyway, it's frequently a combination of those things. Okay? And about 62%, that was in a Canadian survey, had difficulty falling asleep, and about half of those also found that that had a significant impact on their functioning. So if we are starting to tease it apart of what we are actually dealing with, then we can divide those 85 different disorders into conditions that result primarily in making us fatigued and sleepy during the day. Then we have the various conditions that result predominantly in what we call insomnia type of a presentation. Then we have the conditions that result in unusual behavior and sleep. I do a lot of the medical legal work in this country. I actually published a paper on sexual behavior and sleep, of how you can carry out sexual activity when your brain is actually in the sleeping state. Some people are actually much better doing it at that stage. Okay? But you can imagine that it has all kinds of potentially other connotations as well. Okay? And then you have the various conditions that are a result of a mismatch between your body clock and your scheduled sleep time, which we will find also in individuals that have lack of structure to their awake and daytime functioning, such as individuals that are not working anymore, might be on disability, etc. Anyway, we have to look at problems can be related to what we call a primary sleep disorder, and some examples are sleep apnea. Restless leg syndrome is this creepy, crawly sensation that you might have in your legs when you're trying to relax in the evening, and it can be related to some metabolic effects, low back pain, low iron, etc. Periodic limb movements are those leg jerks and kicks, which I have to be careful. I had my shoe fly one of those days when I did the demonstration. But that can shake up the bed and drive the bed partner crazy. Then you have the various psychiatric conditions, predominantly mood disorders, anxiety disorders, etc. Various psychosocial stressors, direct effect of immune dysregulation, virus progression, direct effect on central nervous system, comorbid medical conditions, and adverse drug effects related either to the HIV medications or to some other medications that the individual might be on. There is also a circular relationship, and Harvey Moldovsky here in Toronto did quite a bit of work on that, on the connection between the immune system and sleep, okay? In terms of when you are chronically sleep deprived and you're not getting the right kind of sleep, how your immune system is run down as a result of that, making you much more vulnerable to certain infections, including upper respiratory tract infections in particular, okay? All right, so this is what normal sleep looks like. And if anyone took any training about sleep in your whatever training you had, then this is a typical picture that you are going to be shown. So we have now 4 stages of sleep. We used to have 5. The 4 stages now essentially REM sleep, which is a dreaming stage that is marked here in red bars, and it's progressing, becoming longer and longer, more in cycles towards the second part of the night. and it's a relatively unstable physiological state. Then you have stage 1. So any one of you that is still hearing me there, but I'm starting to fade slowly, and you wonder, what is he talking about by now? Okay, you are probably getting into stage 1. Stage 2, okay, is decent stage of sleep, but very sensitive to both internal and external stimuli. So a dog barking, a truck passing by your window, your bed partner or yourself going like that about 20 inches from your head will have an effect, okay? And stage, what we call slow wave sleep. Now we call it N3. It used to be stages 3 and 4, are really the deep stages of sleep that we need in order to feel refreshed. If you are not getting any of that stage, you can be practically asleep for 15 hours and still feel like you were run over by a truck when you wake up. And most people here in this audience ideally should be having about 15 to 20% of their sleep time in the deep stages of sleep. Now, ideally, most of us should be getting between 6 to 8 hours of sleep. Okay, there are some variations on that, but the answer to how much sleep you need, as many hours as you need in order to function optimally for yourself, fully awake during your awake time, which is not always the daytime, since we have about 50 million shift workers in North America alone. Okay? This is much more what the picture looks like in a patient. Okay? An absolute mess. Okay? Lots of what we call microarousals. Okay? That nice progression is not there, hardly any deep sleep, etc., for a variety of reasons. If we look more specifically at various causes of insomnia, which is by definition problem falling asleep, staying asleep, waking up too early, or waking up having the sense of I don't really sleep. The patients describe it unrefreshing sleep, etc. They never know whether they are asleep, awake, they keep on looking at the clock, etc. Then it can be primary, and primary typically is your go-go-go hyper type of a professional with high levels of adrenaline, maybe a bit of a type A perfectionistic individual that is doing okay till they go through a period of crisis, okay? And now sleep gets out of hand, and the head gets going. What's wrong? I need a CAT scan. Something wrong with my head. I'm having an important meeting tomorrow. It's 2 o'clock. How am I going to function like this? I have to do a presentation. I'll embarrass myself. I'll fall asleep in the middle of it, etc. The more you do that, and the more you stay in bed, eventually your bedroom becomes conditioned as a place of struggle. So long after the original trigger is gone, now those people fall asleep in front of their favorite football game in the family room when they're not trying to sleep. But the second that they put their head in the pillow in their own bedroom, it's like somebody injected them with something. Sounds familiar? I'm sure that there are some people here that can identify with that. Then we have the various insomnias resulting from non-HIV medications, and some of those are listed. Steroids are a big one, some of the bronchodilators, etc. Various medical conditions, kidney issues, lung, congestive heart failure, people that have to wake up a lot to urinate at night. The psychiatric conditions are a big one, but the majority of sleep problems are not psychiatrically related. Okay? So it's not a given when somebody has a sleep problem that they must be having a major psychiatric conditions. Various substances, alcohol is a big one in terms of wiping out the quality of sleep, okay? And various street drugs, including the occasional joint that some people might be using for nausea and pain, can create this fatigue, a motivational type of a syndrome, okay? All right, those conditions, regardless of what they are, can have a major effect on the individual's quality of life. They can affect adherence with medication and with treatment plans, and they can also have a significant effect on how our coconut and the stuff between our ears is usually working, okay? And this is a study that essentially showed that individuals with insomnia are 2.5 times as likely not to be adhering to their medication regimen compared to the control group, okay? So the key message here is, okay, that healthcare professionals should be asking routinely patients, and it doesn't take a lot, okay? There is a screening questionnaire that we developed, which the clinic nurse can hand out. Michael has been using that very effectively. It takes less than 5 minutes to fill out. It has a key at the end. You practically look at the key, and it tells you high risk for this, high risk for that, etc. Anyway, healthcare professionals should also determine whether the problem is acute, chronic, primary, or secondary. And those are some of the definitions. Acute is usually less than a month, chronic more than a month. Now the definitions start changing to more than 3 months. A lot of the patients that I see, it can be much longer than that, okay? And I described already primary insomnia. That condition in particular is a diagnosis of exclusion, okay? And I think that there are a lot of individuals here that would experience that or know somebody that experiences that. Secondary insomnia, again, can be associated with various psychiatric conditions, okay? And those things always have to be excluded. There is a very strong overlap, in particular depression, anxiety, and panic attacks in some of the patients that we are dealing with, certain medications, including some of the psychotropics. Prozac taken at bedtime is not exactly good for your sleep, okay? It's a stimulant. And the number of times that I see is that people are being given a prescription for an antidepressant, let's say, and the prescription says take once a day, and the patient or the pharmacist decides, oh, every medication is taken at bedtime, so let's do this one at bedtime as well, sometimes can be the cause of the problem, okay? Binge drinking literally makes your brain from the sleep perspective look like the one of a 70 years old. And sometimes it's completely irreversible. And then you have the various disorders. Okay, sleep apnea, for example, we see in about 10% of the population. 50% of individuals with sleep apnea don't have to be heavy and are not obese. It's related much more to the jaw structure, including the fact that we stopped taking the tonsils out. Okay? My generation, everyone lost their tonsils in childhood. We stopped taking the tonsils out. We created this completely new generation of children out there with significant apnea that manifests much more with attention deficit problems. Usually a 6 or 7 years old is not complaining of falling asleep behind the wheel of a car, has difficulty sitting still, okay, and moving about continuously as a way of self-stimulation, okay? This is an example of the screening questionnaire that was developed that is also available to anyone. Frequently, it's useful to hand out a quick sleep log, which you can send the patient away to have more of a structured documentation of their sleep pattern, which at times gives you really an idea of what's going on there. Most of us, if somebody asks us, tell me what your sleep schedule was for the last 2 weeks. Most of us have a vague idea, but we cannot really give an accurate answer. So when you have to mark it down, it gives you a much more of a useful impression, again, in a very cost-effective way. And this is actually what we call a sleep hygiene program that we developed using some common sense guidelines, okay, of relaxation before bedtime, keeping a relatively regular schedule, restricting total time in bed. One of the most common mistakes that people make is spending too much time in bed resting, okay? It's like if I take this glass of water and I allow it to be spreading all over, it's going to be very shallow. But if I restrict it between the walls of this glass, it will force it to become deep, okay? All right. That's my hint that they're going to lasso me down in a minute, okay? So those handouts are also available incorporating some of those principles. As far as pharmacological management, okay, the idea is to use the most appropriate agent, okay, when you have to, for the shortest period of time that is needed, but in some cases it has to be longer, while working on behavioral measures So they have something to fall back on when the pharmacological agents stop being effective. And for example, while in somebody that you suspect that is a snorer or might be having sleep apnea, using a benzodiazepines is not a good intervention because it might be making the snoring or the apnea worse. For controlling of nightmares or night terrors or sleepwalking, small dose of a benzodiazepine can be very effective. Okay? So to get back to the cases, okay, in this particular case, what Michael picked at that point was a small dose of lorazepam for 2 weeks. Okay? The nightmares stopped completely. At the end of the 2 weeks, the dose was reduced, discontinued, and the nightmares never returned, which illustrates that there is a self-limiting factor there as well. The second patient was suspected as having sleep apnea, was sent to a sleep clinic, okay, assessed by a sleep specialist, was diagnosed as having a significant degree of apnea, and was put on what we call CPAP treatment, which is a treatment with a mask for the significant cases of apnea, although there are other treatment modalities. Now, just to show you what it looks like, okay, this is a 2-minute segment. This is normal breathing. This is what an apnea looks like. Look at the slowing down of the heart here and the speeding up of the heart here, the snort here, the effect on brain waves, the legs kicking, and this is a fluctuation in oxygen. This is the same patient the next night on CPAP. And the picture is worth 1,000 words. So we can make a difference as long as people actually use it. And the trick is to work with people on how to use it on a regular basis. There are roughly 150 sleep clinics across the country, about 125 in Ontario and about 25 across the rest of Canada. I'm going to refrain from political statements here of getting into why is that the case. What you have to be careful with that out of the 125 clinics in Ontario, probably 90% of them, if not higher, can deal exclusively with telling you whether you have sleep apnea, yeah or nay, but cannot deal and are usually not interested in any other condition. So look particularly for a clinic that has interdisciplinary expertise, the same way like dealing with HIV, for example. It's not a one-trick pony as far as management and intervention. It usually should be done in an interdisciplinary setting, looking at the biopsychosocial effects, etc. Here I'm preaching to the converted in that regard. Okay, and if anyone, the Canadian Sleep Society has a list of clinics, some of the major teaching hospitals, where a lot of the clinics are located as well, have some very good interdisciplinary clinics as well. Okay, anyway, to conclude, when faced with an HIV-positive patient, sleep-related complaints should always be explored. Use some of those common tools, and an interdisciplinary approach can be very effective in diagnosing and managing a lot of those conditions. And I managed to squeeze an hour and a half into 30 minutes. You were a wonderful audience. I didn't hear any snoring yet. So if I have a... Thank you. And do I have some time for 2 minutes for questions?
We can have 2 minutes.
All right. Otherwise, people can catch me on the side, okay? And I'll be glad to answer any questions that you might have outside. Any questions? Go ahead.
Why do we have to sleep? What is the reason for sleep?
If I would be able to answer that question, I would be candidate for the Nobel Prize. Okay? That's a very good question. Okay, there are various theories there. Restorative theory, it has a defensive mechanism, okay? It has to do a lot with cognitive functioning. For example, you need certain stages of sleep in order to transfer things from short-term memory to long-term memory. It has a problem-solving element, and it has also an energy-saving conservation kind of an element, including giving your body the chance to recover from injury for certain things that you experience during the day.
Why can't we not remember
because we remember only the dreams that we got awakened in the middle of or very shortly thereafter. But some individuals can have much better recall of their dreaming, including having the ability of becoming aware of the fact that they are dreaming and change the outcome of dreaming, which is what is called lucid dreaming. Okay? You had a question here.
Do all antidepressants affect you? You shouldn't take them at bedtime?
No. There are some antidepressants that are great to be taken at bedtime, and those are usually the most sedating ones. So Remeron or mirtazapine, for example, I will use in an individual that has a sleep problem, but also has depression. Okay? Prozac or Effexor, which is venlafaxine, is more of a stimulating one, or Cipralex, again, is more of a stimulating one. I will use those things more in the morning. Okay?
Hi, do you know if taking PrEP causes any sleep disorders?
If taking?
PrEP, pre-exposure prophylaxis.
I will have to look that one actually up, okay? But various studies that looked at various compounds outside of some of the nightmare issues with equivalence, which was specifically identified, the incidence of sleep disturbance with a lot of the medications was in the ballpark of 2 to 3%, okay? And they really did not differ significantly from one compound to the other, okay? All right, you'll have to catch me on the side, okay?